Good morning to you, members of the Healthy Caribbean Coalition. My name is Aloma Spencer Johnson, and today I'm going to present to you a proposed intervention for addressing teen and adolescent suicide in the Caribbean. The name of this program will be Together We Can Make It. Now, in the Caribbean, sufficient information is not given to mental health. Therefore, symptoms go unnoticed, leading to the public health concern of suicide among teenagers and adolescents. 35% students admitted to suicidal ideation in their lifetime, with 19.9% experience the thought and 25% thinking about it often. When we look at the data for suicide, it's a pretty serious problem. According to the World Health Organization report, Guyana is 5 times higher than the world average suicide rate. There is an estimated 1,500 to 2,000 attempted suicide cases each year and one attempt every 5 hours in Guyana. In the 13 to 15-year-old age group, 14.7% of females and 8.2% of males reported feeling lonely most of the times. Findings show that 21.5% females and 14.1% of males reported that they seriously considered attempting suicide. Let's take a look at these facts and figures for suicide from the World Health Organization. Suicide is the second leading cause of death among 15 to 29-year-olds. In higher income countries, the suicidal rate is lower. 75% of suicides occur in low and middle income countries. There are more deaths from suicide than from war and homicide together. Now, suicides are preventable. The key is a comprehensive, multi-sectorial approach. According to the World Health Organization, 10% reduction of suicide rates is the target in the Mental Health Action Plan for 2013 to 2020. Now we know that the teenage years can be a challenging period in a child's life. And some of the contributing factors to teen and adolescent suicide are poverty, a family history of suicide, depression, and lack of education. There are many socio-ecological influences as it relates to this issue of suicide. Although it's an individual decision, it impacts relationships, interaction with society, and the person's cultural beliefs. The levels of the socio-ecological model can be used as a focus when strategizing prevention methods and identifying potential areas of focus. It plays an integral role in determining the approach to combat maternal and child health issues. In viewing suicide in teens and adolescents, a family history of depression can contribute to how they feel with the issues they are faced with while they are maturing. At the interpersonal level, support of family and friends can positively influence the outlook of the victims. To influence policies, the organizational level must be included. The local health department can provide systems whereby clients can follow up with appointments, such as reminders prior to appointments for confirmation. The community, in addition, needs to be equipped with the resources to monitor and provide counseling for those suffering from depression and other at-risk factors while dealing with suicide thoughts. Everyone plays an important role in suicide prevention. Therefore, as a public health educator, there are major responsibilities which can be enforced in the prevention of suicide while using this socio-ecological model. Some of the benefits and hindrances of this model includes for suicide, at the individual level, knowledge about suicide prevention and awareness. One hindrance, a history of depression and family suicide. At the interpersonal level, a supportive families will be beneficial to a child. A hindrance, cultural beliefs about suicide prevention and treatment. At the organizational level, one benefit is healthcare facilities to provide appropriate services, and one hindrance, lack of insurance coverage. To complete this model, let's take a look at the community and policy levels. One benefit of the community level is media campaigns to provide suicide awareness, and one hindrance, lack of mental health professionals in the community. At the policy level, one benefit is health policies regarding reporting suicide, and one hindrance, clinical programs, insurance screening policies. To address suicide in teens and adolescents, I would use 3 evidence-based practices. 1. Attachment-based family therapy. This program consists of 5 therapy tasks in a 16-week treatment plan for youths 12 to 24-year-olds who have expressed suicidal thoughts, attempted suicide, or experienced some type of trauma. Then, applied suicide intervention skills training. This model will train families and friends on how to identify at-risk teens and adolescents and provide information on making appropriate referrals. Lastly, I will use the suicide prevention screening in schools, which will provide education, and it will be implemented by providing in-service training for teachers and staff through curriculum screening and self-reporting to identify potential suicide adolescents. The success of this program, will be measured by the following. By June 2019, 80% of schools who identified at-risk adolescents or youths in the Caribbean will see a decrease in numbers during the first year of therapy. By June 2019, there will be a 60% reduction of at-risk adolescents and youths showing up at psychiatric emergency room for suicidal behaviors. And by June 2018, 80% of school staff will receive training on how to identify students who are experiencing suicidal ideation. As with any new program, I anticipate some potential challenges. However, I have a system-based approach in place which can help solve these challenges. Some of the challenges are lack of resources, challenges in receiving data, and low participation. The system-based approach solutions which will be used will be the Population Services International Network, the Caribbean, Port of Spain General Hospital, the Silver Lining Foundation, Choose Life, Say No to Suicide Media Campaign, the University of the West Indies, the Caribbean Public Health Agencies. This collaboration will assist in reducing suicide rates among teens and adolescents. Before we leave, let's take a look at this logic model, which can be used to measure the effectiveness of the program. Together we can make it. Now, bearing in mind, our goal is to reduce suicide rates among teenagers and adolescents in the Caribbean. Some of the resources we'll need for this program will be licensed masters social workers, training materials, trainers, case managers, teachers, and permissions from parents. These resources will be used for our activities for 16 weeks of therapy, or mental health training, or referral for preventive services for suicidal victims. And participating in this program will be school staff, teens and adolescent suicide victims, those at risk, and public health personnel. Now we have short-term, medium, and long-term goals. One short-term goal is families and friends will be knowledgeable about behaviors leading to possible suicide thoughts. Medium goal, 60% reduction of at-risk teens and adolescents showing up at the psychiatric emergency room. And by 2020, 90% of at-risk students will receive preventive services and therapy. Information for this proposal was retrieved from the following sources. I'd like to thank everyone for attending today. Thank you.